online also, as opposed to the course 2 days ago, which they weren't, but they should be now if you were in that course. And then evaluations are also online, and you have to complete the evaluations to get CME credit after the meeting. I also have a couple disclosures I've listed here. I do receive some small amount of royalties on sales of some EMG educational products that the AAN sells, as does the AANEM. I'm not sure I'll be using those in this course, but you need to know of that disclosure. So, a couple preliminary questions here. How many of you were in the course on Sunday, the EMG 1 course? Okay, so some of you were there. This is going to be kind of a continuation of that, as I mentioned in that course. And how many of you perform EMG in your practices currently? Okay. How many of you don't perform EMG, but you're planning to at some point in the future? A couple people. So most of you, how many of you aren't planning to do EMG, you don't do it, and you have nothing better to do, so you're here? A couple of you. Okay. All right. And how many residents are fellows? Okay, good. And how many of you have already mastered EMG waveform recognition? So why are you here? If you already mastered this, why are you here? I'm sure we have a wide range of experience in EMG, and some of you have been probably doing this for many years. Some are new to it. The residents and fellows, you're probably just learning. And I believe, and I'll show you during this session, that no matter how long we've been doing this, we can continue to master our skills. And that's going to be the goal of this program, is to help you improve upon the skills that you already have. So here's the objectives. And again, I know a lot of people are wandering in, so if you have an open seat, if you don't mind just squeezing in one seat or two so people can find a place to sit. So here are the objectives of the next 2 hours. First of all, I'm going to spend a few minutes just discussing in a general sense the skills and the things that are required to master a skill, the skills that you need to become good at mastering EMG. We'll begin to apply these skills as it relates to EMG waveforms, and most of what we're going to focus on, at least the first part of the program, is going to be on motor unit assessment. That's where we spend a lot of our time trying to figure out our motor unit potentials, normal or abnormal. We will talk about some of the other waveforms, and depending on how this goes and how much time we have left, if there are questions about any type of waveforms or some examples that you may want to see, we can certainly show additional examples. This, I hope, is not like a typical course that you've been to. This is going to be very interactive. I want it to be interactive. I don't want to stand up and talk the whole time. I'm going to be asking you lots of questions, showing lots of examples, and at any point, if you have a question about something, if it doesn't make sense, you want me to play something again, please interrupt me. Please raise your hand, because that's how we're going to learn. So I don't mind that at all. And the main objective is, after 2 hours, when you walk out of the room, you will have mastered EMG waveform assessment. So you're probably sitting here going, this is great. In 2 hours, I'm going to be an expert at EMG. And that's what I hope. Now, 2 hours may be a little bit short. In fact, if you think about a skill and learning a skill, and how long do you think it takes to master a skill? Any idea? How long if you're from start to finish, to become an expert at something? How long? I hear years. How many years? 5 years? 40,000 hours. Okay. Any other? 2 hours maybe for some of you? Anyone hear of the 10,000 hour rule? Have you heard of that? A lot of people have heard that 10,000 hours are required to master a skill. If any of you have ever read the book Outliers by Malcolm Gladwell, which is a fantastic book about factors that lead to people excelling, he references the 10,000 hour rule. I was interested in that. I actually went to the reference. I pulled the paper. There was actually a study on this. This came from the paper. This study came from Germany. It was in Berlin back, I think, in the early 90s. And what they did is they went to one of the premier music schools in Germany, and they took some of the professors, they actually asked them to identify a group of students who they thought were the top students. They were the ones that were going to go on and play professionally. And then they identified a group of students who they thought were just a notch below the best students. They probably weren't going to make it professionally, but they were excellent. And then they went across the school to the music education department. They asked some of the professors there to identify some of the best students in that section. And then they did very intricate surveys to the students. They asked them all sorts of things. How much time did they practice? What type of practice? When they practiced? When did they sleep? And all sorts of things. And what they came up with was this graph. And the graph shows that the best students had estimated that they had practiced by the age of about 20, about 10,000 hours. Same as professionals. The students who were a notch below had practiced maybe about 8,000 hours, and the students who would go on maybe to become music teachers and not play professionally, not that there's anything wrong with a music teacher, but had estimated they had put in 5,000 hours of practice. So that's kind of where that number came from. And this has been duplicated in other studies as well. So any idea how long 10,000 hours is? How long is it? It takes 10,000 hours to master something. How long does that take? What do you think? It's going to be interactive, so shout something out. 10 years? It depends, right? It depends on how much time you actually are practicing. So if you practice a skill every day, every second, you didn't take a break, you didn't sleep, you didn't take a day off, you didn't eat, it would take 416 days. It's a little over a year. If you practiced a skill 8 hours a day, it would take about 3.5 years. That's every day without taking a break. And for us who don't perform EMG 8 hours a day every day, if you do it, let's say 2 hours a day in your practice, it does take about 13 years. That's a long time. For those of you learning, you're saying, oh my gosh, it's going to take me 13 years to do this, to learn this. Well, I'm going to hopefully show you, and we're going to learn that it probably doesn't take a full 10,000 hours, depending on how much effort you put into learning and practicing waveform recognition. So, as you think about learning a skill, whether it's playing a musical instrument, whether it's playing golf, for example, whether it's learning EMG, waveforms, what conditions do you think are necessary to master a skill? What are the optimal conditions to really become adept at a skill? What do you need? You need a mentor, a proper mentor, okay. Concentration? Is that concentration, right? Okay. Interested and passion, okay. What else? Feedback, guidance. I didn't hear that, sorry. Say it. Time, okay. So you need practice. As I said, you need a lot of practice. Yeah, so those are all important. And some of the learning theorists, the people who study, the scientists who study learning theory, have suggested that there are 4 main criteria that are optimal, that help for optimal learning of a skill. The first is motivation. You have to want to learn EMG waveform recognition. You can check that off. You're here at 7 in the morning on Tuesday morning and you're not doing the duck tour or something in Boston. So you have to be motivated. You have to, but it's more than just I want to learn a skill. I'm going to be dedicated to doing what I need to do to become an expert at that skill. You need instruction, obviously. You need to be taught how to assess a motor unit potential. How do I hit a swing a golf club the right way? So you need instruction. You need feedback. That's really critical. And that, for us, I think, is one of the more difficult things. If you're like me, you're not performing EMG with someone standing over you saying, no, you're wrong, or that I would assess this motor unit differently. You don't have that feedback on a day-to-day basis to tell you if you're doing things right or wrong, or you're analyzing the potentials right or wrong. There are some tools, and I can talk to you about that at the end, but I'm going to show you how you can use self-feedback to improve your skills. And then repetition. You have to perform it over and over. And there are a couple of different ways of doing this. One way, the usual approach to learning a skill, is what's been termed the naive approach. This is the approach that I took when I first moved to Jacksonville 15 years ago, and I learned to play golf. Prior to that, I played a little golf. I enjoyed playing golf, but I embarrassed myself most of the time. My goal was to get the ball in the air rather than trickle along the ground, and to at least make it go forward when I hit the ball. And I would go out with colleagues and friends, and I couldn't do that, and it was really quite embarrassing. So I decided when I moved to Jacksonville, I want to learn to play golf. I want to learn to the point where I'm not embarrassing myself. So the first year I took a few lessons. My neighbor was a golf instructor. I took some lessons, and he taught me how to hit the ball in the air, be consistent. I practiced over the year. By the end of the year, I was pretty consistent at not embarrassing myself. I didn't score well. I wasn't really good, but I can go out with friends and consistently hit the ball. After that, I would play about twice a month. I would go to the driving range for about 15 minutes before a round of golf. And I figured if I play twice a month with my friends, over time, I'm going to get better and better, and my scores are going to drop. Well, they didn't. I continued to hover sort of, if I could break 100, that was good for me. So that's kind of where I was, and I thought, well, I'm playing, but I'm not improving. And that's the problem with this type of approach. The problem is that I reached an acceptable level for me, that I wasn't embarrassing myself, so I didn't continue to do dedicated practice. I just went out and played. It was much more fun to spend 3 hours playing a round of golf than practicing for 3 hours. So once my skill became sort of automatic, I stopped improving. And that can happen to all of us. There's suggestions that happens just as to us as physicians. If we don't keep up our physician skill, we may not be as good of neurologists as, perhaps as younger neurologists who are learning and are reading and are continuously improving their skills. And sometimes you can do the same thing over and over. That's not the right thing. If I'm swinging the club incorrectly, I might be doing that over and over and over, and my skills are dropping. So a better method, at least, again, and this is from some of the learning theorists, is to use something called deliberate practice or purposeful practice. Anyone familiar with this concept? You've heard this? Okay, so this concept, it's a very simple concept. It's basically identifying highly structured activities that are solely designed to improve a specific skill. And these activities are not very enjoyable, but they have to be done if you really want to improve. And you can't do the same activity for hours upon hours. It requires very focus, and someone said concentration. You have to concentrate to try to improve a bite-sized skill, if you will. And I think of this as sort of the driving range approach to learning to play golf. So again, if I have 3 hours or 4 hours, it's much more enjoyable to play a round of golf. But if I took those 4 hours and just practiced that 50-yard approach shot with an instructor giving me feedback, and that's all I did for hour upon hour, I'm going to improve that one skill. And if I can do that with each type of shot or each type of club or whatever, and I put those individual skills together, then my overall skill is going to improve. And that's what we're going to start practicing here with respect to EMG waveforms, this deliberate or purposeful practice. So you're here for EMG, not to talk about golf or musical instruments. So for EMG, it really requires 2 skills to analyze the waveforms. The first skill, which I would call a simpler skill, is pattern recognition. That doesn't take very long to learn. But that's the skill, and I mentioned this on Sunday morning, that allows you to identify what the waveform actually is. Is it a fibrillation potential? Is it a motor unit potential? Is it an end plate spike? The more difficult skill is the motor unit assessment. You have to assess a variety of parameters of the motor unit, and you have to make certain assessments that are difficult for us to learn to do. And that's where we're going to be focusing most of our attention on. And as you know, most of you perform EMG. This requires training your ear. It's auditory recognition and training the skills of your ear to become very accurate in measuring these different potentials. So let's give an example of a simple skill. So we'll first talk about the simple skill of EMG waveform recognition. So let's practice the simple skill. I'm going to play a sound, and I want you to shout out what the sound is. So what's the actual sound? A bark, okay? What kind of animal? A dog. How do you know it's a dog's bark? You've heard it before, okay? It's hard to put into words. It sounds like a dog's bark, right? You've heard dogs. Okay, what about this one? That's a positive sharp wave. You have some very interesting patients. So what's the sound? It's a bark. A seal or a sea lion, right? So I guarantee you haven't spent 10,000 hours listening to dogs and seals before, right? You've spent very little time. You probably learned as a child, but this is a simple example of a simple skill. You put an animal to a sound. You do that a few times. You make a couple comparisons, and then you can become very good at recognizing these big differences in sounds. So that's somewhat of an equivalent to recognizing waveforms, what the waveform is. Obviously, they're not as different as seals and dogs, but when you have learned this, they actually are quite different, and you can very rapidly, within a second or so, identify the different firing patterns. So the skill that you have to master to recognize the waveform are the firing patterns, and I alluded to this the other day. The firing pattern is the change in the interspike interval of a repetitively firing spike. Okay, so every spike, everything we record from a muscle fires repetitively. And the interval changes. So, and whether that change is a definable change or undefinable change or almost definable change defines what the firing pattern is. So potentials that fire in a regular pattern have a definable change in that interspike interval. It may be a gradual linear change, it may be no change, or it may be an exponential change, but we still consider that as a regular firing pattern. Potentials, or spikes that fire with no definable pattern, are considered irregular. So sometimes the interval is long, then short, then middle, then longer, so it's very random. And then motor unit potentials fire in between that. They fire in a semi-rhythmic pattern. So there's almost a definable change, but not quite. It changes just slightly, the intervals. And you have to be able to recognize that by sound to identify what the potential is. When you're doing motor unit analysis and all these other things we'll talk about in a few minutes, we're doing that on motor unit potential. So you have to determine that the spike is a motor unit potential. So let's practice this real quickly. Let's just make sure you understand the firing patterns. I'm going to play 5 examples and just identify which of the firing patterns it is here. And we don't have a fancy audience response system here today, so we're going to use the old-fashioned one, which is fingers. So if you think that the example is regular with a linear gradual change, hold up 1 finger. If you think it's semi-rhythmic, hold up 5, and so forth. And everyone has to answer. That's how you learn. And it's not a dog's bark, I'll tell you that. Okay, hold up your hand so I can see. I'll play it again. Is that regular, irregular, semi-rhythmic? So I'm seeing lots of 1s and 2s, and I'm seeing some 3s and 4s, and I'm seeing a mix, but it looks like mostly 1s and 2s. So this is regular. Try to tap it out. It does gradually slow, so it's not totally fixed. It does gradually slow at the end, so it's a linear change, but it's regular. If you're not sure, try to tap it out. If you have good rhythm, you should be pretty accurate at tapping it out. What is this potential? A what? Fibrillation potential. So fibrillations fire in a regular pattern like that. They typically slow down. How about this one? So that's a single spike. So I'm most fours. Okay, good. So what is that discharge? End plate spikes. That's an end plate spike. That's irregular. I'll play it again. Here's some very short intervals and long gaps. Okay, that's an end plate, so you don't want to misinterpret that as a motor unit potential or a fibrillation potential. How about this one? So hands up, I'm seeing the number of hands, most fives. Yes, so that is semi-rhythmic. So that is a what? That's a voluntary motor unit potential. It's the only thing that fires in a semi-rhythmic pattern. If you can't recognize it, I'm going to play it again. Listen to the interval change. It's not totally regular. It doesn't go bup, 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 bup. It changes. Bup, 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 bup. There's a slight variation. Can most of you hear that variation? That's a you don't have to know what the patient's doing. That's a voluntary motor unit potential. And then here is another one. It's a very distinct waveform. It's a little hard to identify this, but what do you think? 3, so most people 3, yeah. So that actually has an exponentially changing waxing or speeding up and slowing down rate. So, that's hard to identify that it's truly a regular, but it does have an exponential change that can be predicted if you knew the formula. But that's a myotonic discharge. And then the last one here, oops. Well, can't get that one to play. There we go. That one's not playing. Okay, that one's not playing. That sounded like this. Is that regular or irregular? That's regular. That was supposed to be a CRD. Okay. So we're not going to spend a lot of time practicing the firing patterns here. That's not the intent of this. But if you're learning or you're having trouble, you just have to listen to examples and compare them. And again, as you all know, the sound is more important. So I'll show you 3 examples of an end plate spike, a fibrillation, and a motor unit potential. You can look at them, but it's a little hard to see visually what the firing pattern is as much as the sound. So that's a little easier. It's slow. Everyone, what do you think that is? Fibrillation. So that's regular, very slow. There are 2 fibrillations there. This one. Motor unit potential. Right. So it's a little hard if you look at this. It looks pretty regular, but if you took a ruler and measured the inner spike interval, this one's a little bit shorter than this one, so it does change a little bit. And that, again, the sound is going to allow you to identify it better than just looking at it. So that's a motor unit potential. And what is that? That's an end plate spike. So that's irregular. You can see short intervals and very long intervals and very random. So any questions just in general about firing patterns? And again, if you have questions, don't be shy about asking, because probably the person sitting next to you is wondering the same thing. No, it's a good question. So the question is, if I'm differentiating a motor unit from a fib, do I depend on the amplitude? The answer is absolutely not. The only thing I depend on is the firing pattern. You can have, I showed this in the course on Sunday, you can have fibrillations that are very large if they come from a hypertrophic muscle fiber. And you can have unit potentials that are very tiny from a myopathy. So you cannot base any differentiated, you can't distinguish what a waveform is by what it looks like in anything. I mean, there's some exceptions. Myotonic discharge, you'll see in wax and wane. CRDs are more complex. But if you have a single spike, an end plate spike, a fibrillation potential, and a motor unit potential can look identical. So that's why you have to learn to listen to that pattern. Okay, so we're going to move, that's simpler. So we're going to move into the more complex motor unit analysis here. And again, I'll give you an example before we get into waveforms, but I'll play a sound again. If you didn't know what that sound was before, hopefully in 15 minutes you learned it. So there's a dog. And what about this one? Okay, so you think it's a dog? Yeah, it sounds different though, right? So you think it's some people said Chihuahua, a small dog. That's a different kind of sound, right? But you still know it's a dog, right? So one may have been a big dog, one was a small dog. So if I asked you exactly what type of dog those were, each of those were, it's a little hard to know, to distinguish different breeds by their barks. And that, in my mind, is a little bit like motor unit assessment. It's a little hard to determine, is a motor unit long duration, is it normal, is it stable, is it unstable, and things like that. That takes more time to learn and a more complex skill. So that's what we're going to be practicing here. We're going to be focusing on assessment of the motor unit. And I'm not going to get really into a lot of pathophysiology here, but if there are questions, certainly ask. But remember, the whole reason we're doing this is we're trying to determine what type of neuromuscular disease is going on. And in many different diseases, patients can have fibrillations, they can have other spontaneous waveforms, so we have to use our motor unit assessment to determine, is it myopathic, neurogenic, or something else. The motor unit, as you all probably know, it's an anterior horn cell, it's the axon, and it's all the muscle fibers that are discharged when this anterior horn cell discharges. And in the pickup area of our needle recording electrode, we summate a group of those muscle fiber action potentials. Each one is giving off a little action potential. They're firing all at about the same time, so we summate those with our needle and our amplifier, and we record that motor unit potential. So this waveform tells us what's happening with this motor unit. And we have to assess a variety of parameters of the motor unit to determine what the disease is, or the time course of the disease. So we assess the rise time, which we're not going to spend really any time today on, but that simply tells us that we are okay at assessing everything else. It tells us that we're close. When we have a short rise time, that we're very close to the muscle fibers, and it makes for more accurate assessment of duration and phases and size of the potential. But these are the other parameters that we have to assess in every motor unit. And I'll show you as a recurrent theme is if you spend time assessing them on every motor unit, you can be very, very accurate just as accurate as quantitative EMG, formal quantitative EMG. So a question for the group. There's no right or wrong answer here. So if you think about it in your practice, when you're performing a study, how much time would you say on average you spend assessing the motor units in one muscle? So how many of you spend more than 10 minutes in a muscle assessing motor units? Okay, then there's no right or wrong answer here. How many between 5 and 9 minutes? 1 to 4 minutes? 1 to 60 seconds? 1 second to 60 seconds? I guess there is a wrong answer. If you're less than a second, that's probably not good. So most people are probably in the 2 to 4 range. And I would say, like a lot of things, it depends. If something's horribly abnormal, floridly abnormal, you may not spend a whole lot of time. If something's borderline, you're looking for subtle changes, then we may spend somewhere in the 2 to 3 range here. Now, another question, if you think about your routine exam, how many muscles on an average EMG study would you examine in a patient? So let's say a radiculopathy, a patient who comes in with arm pain or leg pain. How many muscles do you examine? 6? Anyone do less than that? Maybe 5, 4 to 6. Anyone do 10? You know, it depends on the problem. But on an average study, I'd say in our lab, we probably do 5 or 6 muscles. And if you think about each muscle, how many motor unit potentials do you think you actually assess in a muscle? At least what? 10, at least 10? At least 10, okay. Right, so whether you're aware or not, I'm sure you are assessing 10 units. Even if you do a quick interference, which we don't do in our lab, but if you have them contract, there's probably close to 10 motor units firing if they're contracting at a strong contraction. So if you add that up, if you do 5 muscles on an average patient, and let's say you assess 20 motor units, that's 100 motor unit potentials in one patient. So if we convert that 10,000 hour rule to 10,000 motor units, then you can reach that fairly quickly. And if you spend the time using these skills to recognize the different parameters and train your ear, you can master this fairly quickly. So some labs, how many of you do formal quantitative EMG on most of your patients? Do you do it on most of your patients? Some. So there are a lot of automated programs. Dr. Bromberg talked about this on Sunday, where you can have the patient contract at a low level. The program will identify the individual motor units and summates them and gives you a mean of all the parameters of the motor units. And those programs are very good, but they're not always accurate. You have to go through and review those motor unit potentials to make sure they're marked appropriately and they're clean motor units. Again, what I want to teach you is that you can be just as accurate in doing this without formal quantitation. So we're going to be practicing what we call rapid quantitation or semi-quantitation, where we're essentially obtaining a numerical value without actually measuring it out. So almost guesstimating it. And a good analogy is if you ever go to a fair, county fair, and they have the guesser, the weight, person who guesses the weight, the ones that are really good can guess people's weight within just a couple of pounds, whether they're tall or short or have a lot of clothes on. And that's because they've done they've learned this skill of making assessments, correcting themselves when they were off, and by making those corrections, they've become very good at it. So let's try this. Let's just go through a motor unit here. This came from a 42-year-old woman with arm pain. And this was recorded from the deltoid. So what do you think about that clip, that example from that recording from that patient? So first of all, do you think this is normal or abnormal? So how many of you, let's show of hands, how many of you think this is a normal recording? Okay, how many of you think it's abnormal? And for those of you who said abnormal, why abnormal? Okay, so there's some issue with recruitment, that there's a single motor unit, it's firing, but we all have motor unit. We have patients where we contract at a low level and there's just one motor unit firing. So what's wrong with the fact that there's just one motor unit firing? It's firing fast. Yeah, too fast. So right, there is reduced recruitment here. So how fast is it firing? That's the harder question, isn't it? Because what you're all looking at is you're sitting there counting. I see you. You're looking. And we're going to take that a step further and help you train your ear to recognize the firing rate of that without having to look at it every time. So this is an example. The motor unit morphology is okay, but it's reduced recruitment here. It's firing too fast. In neurogenic disorders, there are a variety of changes in the motor units. So those changes tell us about the time course of the disease in neurogenic disorders, and that's what we assess the most, people with nerve problems. So the first thing that happens in an acute neurogenic process, this is depicted here in a normal muscle that just has two motor units. In a normal muscle, if there are two motor units, the patient contracts that muscle, both motor units fire. If you lose half of those motor units, the first thing that happens is, in order to generate more force, the motor units that are remaining fire faster and faster and faster, but there are fewer units to fire, and that's reduced recruitment. That's an acute process. Then with reinnervation, as the nerves that are there sprout out, there's changes in the morphology of the potential. They become unstable as the new neuromuscular junctions are just forming and are immature. They develop turns and phases when there's less synchrony of firing of those newly reinnervated muscle fibers, and over time they become bigger, longer duration, higher amplitude as you have more muscle fibers in one motor unit. So we have to determine, when you're assessing a patient, not only are you trying to determine is it a neurogenic process, but you want to give the referring physician some idea about the temporal course. So that's why we have to be able to determine these different parameters. Recruitment is probably the most difficult one to assess, particularly if it's mild. I would imagine if I asked that, and I asked what's the hardest thing for you to determine, most of you would say this. Recruitment is the orderly addition and increased firing rate of motor units with increasing force of contraction. So what happens is, as a patient contracts at a very low level, in one area of the muscle, they may just have one motor unit that's activated, or a couple motor units. And as they increase their force, that motor, in order to generate more force, that motor unit speeds up, and to the point where the threshold of the next motor unit is reached. Now you have two units that are firing. With increasing force, they both speed up, and then a third one is recruited, and a fourth, and a fifth, and so on. So it's this relationship between the number of motor units and the rate of firing here that defines whether recruitment is normal or abnormal. Does that make sense? You have to determine that relationship. If you have reduced recruitment, you have loss of motor units, you get a graph that looks like this. So as a patient contracts their muscle, the first motor unit may be activated at somewhere around 6 or 8 hertz. As they contract further, that motor unit speeds up, but there are fewer units that can be activated. So that unit may be firing at a faster and higher rate relative to the number of motor units that are firing. And that's reduced recruitment. That indicates there's loss of motor units or there's block of conduction along some of the axons. So here's the instruction. I said you have to be motivated and you have to learn how to do this. Here's the instruction. In order to really be good at this and accurate at it, you need to determine first, what is the firing rate of any one motor unit? Number two, how many motor units are firing? And then what's the ratio of the firing rate to the number of motor units? and you compare that to normal. In most muscles, most limb muscles, that ratio should be 5 or less. That means if you have one of those motor units that you can identify that's firing at 15 hertz, there should be 3 units close to that electrode that are firing. If you have one unit at 20 hertz, there should be 4 units firing. If you have one motor unit firing at 20 hertz, that ratio is 20, that's significantly reduced recruitment. And then we can grade it. There are different ways of grading recruitment, but an easy way is to grade it when does the second unit come in. If it's after about 10 hertz in most muscles, not every muscle, if the first one's firing at 10 hertz or above 10 hertz before the second comes in, that's usually mildly reduced recruitment. If it's above 15 hertz, it's moderately reduced, and above 20, it's severely reduced. So does that concept make sense? Are there questions about that? Okay, so let's practice. We'll give you feedback here. So the first step, identify the firing rate. And we're going to use the old-fashioned audience response system. So if you think it's at 1 hertz, one finger, 5 hertz, 5, 10. If it's more than 10, you can do this or hold your foot up, whatever you want. But I want everyone to do this. And you may be way off at first, and that's okay. But everyone needs to answer. So I'll play it again. Keep your hands up. I want to see what rate is this. So half of you are thinking or are asleep or just have no idea. One more time. Let's just turn that up a little. So I'm seeing a lot of 4s, mostly 1 hands there. 4s, mostly around 4 or 5 here, okay? So I'll let you see it, but don't focus so much. I want you to listen to this sound. Same clip. 6 hertz. Okay, this is a 50 millisecond per division sweep, 20 divisions, so this is a 1 second sweep here. So if you have a machine that allows you to use a 1 second, display it in a 1 second sweep, you can count how many times this fires in 1 second. 1, 2, 3, 4, 5, 6. Okay, but listen, if you were 4, that's pretty good. If you said 5, that's good. If you're 6, you can leave. You got this down. If you're 10, that's okay. Or 1, that's okay. But now you have to just listen and say, this is the sound of 6 hertz. Okay, let's try another one. What's the firing rate? It's going to start at a rate, and then what does it end at? Okay, what does it start at? 6. Most people said 6, so okay, what do you think it ends at? I'm seeing a lot of people waving, 10, 13, okay. So you all recognize that it got faster, right? That's good. Okay. And it's not a bark, right? Or a positive wave. So, okay, let's play it. Let's show you. It's up to 8 hertz. Right there. 1, 2, 3, 4, 5, 6, 7. There may be another one in there. So gets up to about 8 hertz. It doesn't change a whole lot. Your ear can hear that change. It's very sensitive to mild changes there. I'll play that again. 6 to 8 hertz. This is still normal in a muscle. A motor unit can fire. I talked about that ratio. The ratio doesn't hold true for the first unit. It holds true when you have 2 units. So you can have 1 unit firing up to about 10 hertz, and that be normal. Okay, so 1 unit up to 8 hertz here. Let's try another. A lot of 10s. Still about 8 to 9. Okay, again, if you want to visually confirm, 1, 2, 3, 4, 5, 6, 7, 8, and then the 9th. You know, it's semi-rhythmic, so it's going to change a little bit as it's firing, but on average, this is about 9 hertz. Okay, still normal. That sound is normal. Another one. Okay. And more people are waving to me this time, so. So 10 hertz, very good. Still normal, still normal. Now, same thing, but what's the firing rate of the motor unit when a second unit starts to fire? Okay, did everyone hear the second one come in towards the end? Okay, you can hear there's a second click. I'll play it again because this is an important one. What's the firing rate, what's the fastest firing rate of the first one when the second one starts? What do you think? 11, 10, so 5. More than double? More than double what? So some people said 10, 11, 6, so somewhere between 6 and 11. Okay, so let's look at it. Same sound, same clip. Listen to it, but let's look. Okay, right now it's firing at 2, 4, 6, 8, 10, 11 to 12 there. Okay. That's where the second comes in. Okay, so it does get up to about 11 or 12 there. That example, in my opinion, is the most difficult thing to recognize. That's mildly reduced recruitment in most muscles. Most muscles, by 11 or 12 hertz, you should already have 2 units. By 10, right after 10 hertz, you should have 2 units. Okay, there are exceptions. The triceps is an exception. Some of the extensors and the cranial muscles, they can fire a little bit faster. But you can hear a little bit of a revving up sound, I kind of think of, when that rate gets a little bit too fast. And that's mildly reduced recruitment. I'll play that again. Assuming that that's in multiple areas of the muscle too. That's a question that often comes up. Well, sometimes in one part of the muscle I get in and I record this and then I move a little deeper and there are 4 units firing at 8 hertz. So you have to average all areas of the muscle to determine if that muscle's normal or not. But if you had this in multiple areas of the muscle, that would be mildly reduced recruitment. How about this one? What's the rate? 12, 14, see 15. 14 hertz. You can count that out. You can hear the revving up sound. It's firing faster. That's a little easier. When you have one unit at 14, 15 hertz, that's reduced recruitment. It's easier to recognize. And how about this? That's going to require a lot of hands and foot waving and head shaking to determine the rate. Any idea how fast that went? 20, it's plus 20, it's above 20, yeah. I guess that's all you really need. If it's 20 plus, then you know it's severely reduced. Take the shortest inner spike interval here, it's almost about 10 milliseconds. I can't, it gets chopped when I stop it, but if it's 10 milliseconds between the two units, that's gets up to about 100 hertz. So it's firing very fast. Sometimes I'm asked, how fast can a motor unit go? And I say 75, 100 hertz, and people say, there's no way. Well, that's 75 to 100 hertz when it gets the fastest. Severely reduced recruitment. Okay, let's continue on recruitment here. So now the next step, so you're starting to learn firing rate. I know in 5 or 6 examples you're not going to be perfectly accurate, but you want to do this, and you can do this with your machine. You can isolate a motor unit, you can estimate without looking at it what's the firing rate, and then you can look at the machine and visually confirm your firing rate. And if you do that, and you have to put effort to do that, you can become very, very accurate in within just a couple hertz. Question? Yeah, so the question is, how do you grade mild, moderate, or severe on recruitment? So there are 2 ways of grading it. The simple that I showed on the earlier slide is if it's grading it based on what's the firing rate when the second unit starts to fire. So if it's above 10 but less than 15 hertz, then I grade that as mild. If it's above 15 hertz but below 20 hertz, moderate, and then severe over 20. The problem is that doesn't always work. You can't just use that rule because, as we all know, many times we put a needle in, the patient contracts at a low effort, and what happens? 2 units fire at the same rate, right, or 3 sometimes. And sometimes those low threshold units fire at a low rate, but the higher threshold units are absent. So the patient contracts, and both of those 2 units fire faster and faster and faster. So you there's no good rule based on the ratio, but if the ratio is above about 7.5, instead of the ratio of 5, if it's about 7.5, then it's moderate. If it's above a ratio of above about 10, then it's probably more severe. So you have to kind of use both of those guidelines to grade it. Other questions? Okay, so you're learning firing rate. Now you have to learn how many motor units are firing. So how many motor units? 1. That's easy. How about this one? Okay, there's 2 there. And I would encourage you, it's hard sitting here with a big screen in front of you, but I would encourage you to listen to the sound of 2 units. It's easy to see them, but listen to the sound, because it's the sound of the rate and the number of units that will help you determine is the recruitment normal or not. So your ear hears the loud one, but you can hear that little thumpy one, smaller one in the back. How about this one? Is there more than two? Okay, there are three or four. There's three there. And it does become more difficult when there are more than two. Once you get three or four or more than that, it's very hard to separate out individual units. That's okay, but you want to at least be able to identify are there more than two units firing. So here there are three. I'm trying to stop it, but here's a big one, and then there are two other ones here. Yeah. Yeah, we'll get to the firing rate and the units here. But yeah, if you want to, so what you have to do is you have to say, okay, there are three units there. You have to try to listen to the sound, if you can, of one of them. Pick one of them out, the louder one usually, and try to determine what is the sound of that. What is it? If it's 15 hertz and there are three units, that's normal recruitment. These are actually firing a little bit less than 15 hertz. Here. These are, let me turn that up just a bit. So these are probably firing at about 8 or 9 hertz with 3 units. So was there another question? Yeah, so this is a really good question. Let me back up for a second to this one. So the question is, what's the best speed to use to visually check, confirm? I'm going to say visually confirm what you're training your ear to do. Most of you, I would imagine, use this sweep. Is that correct? Am I correct? A 10 millisecond sweep? Hopefully you all know what the sweep is you use. So most people, I would think, use a 10 division sweep with 10 milliseconds. So the entire sweep is how long? 100 milliseconds, right? So if you have a motor unit firing at 10 hertz, exactly 10 hertz, the interval between the spikes is 100 milliseconds, so that unit is going to stay in the same spot as it's firing at 10 hertz. If it's firing faster than 10 hertz, that inner spike interval shortens, so it will appear that this unit is moving more to the left. And if it's slower than 10, it'll appear that it's moving more to the right. I have a hard time figuring that out, to be honest. I think it's very hard, especially if you have 2 units firing, to know which way is it firing, what's the inner spike interval of it on this sweep and on this display. Here, you know, it's a little hard to tell. Which way is that going? It's kind of going back and forth. So that's why I've shown some examples where I use a 50 millisecond sweep with 20 divisions. That gives you a whole 1 second sweep. And that allows you to, if you want to train yourself and visually confirm, to count out how many times that's firing. The problem with that sweep is that you can't look at the morphology of the unit as you can here, but a lot of machines have a trigger line that if you trigger on this, then in the bottom of the machine you can see the blown up unit. So that's how I was trained, that's how I use it, if you're really focusing on visual confirmation of recruitment and firing rate. But you can certainly do it this way. You just have to figure out what's the inner spike interval. When you have a unit firing like that, you just have to figure out what's the interval between the 2 spikes, divide that interval into 1,000 milliseconds, and that tells you the rate. Other questions like that? Okay. So let's put both of those 2 steps together. What is the ratio of the rate to the number of motor units. And I will say, I see a few people with your eyes closed. I hope you're not sleeping, and if you're not, you're doing this the exact way that you should be doing it. You should not be looking at the screen initially. You should be closing your eyes, looking away, trying to assess this by your sound. So, firing rate. About 8 hertz. Okay, how many are firing? How many motor units there? One, right? That's a little needle movement there at the end. But so 1 motor unit, 8 hertz. Is that normal or abnormal? Normal. Okay. So that's what I said earlier. That ratio of 5, rate to number of being 5, doesn't hold true for the first unit. Okay. The other point to make here is, are you sure, if you recorded this from a patient, are you sure that there's not reduced recruitment there? Can you say that patient does not have reduced recruitment? No, why not? Okay, you need to know, when does the second unit come in here? This is often a problem, the patients who sort of don't give effort, they come in, they're weak, you're not sure, is there really a neurogenic process or not? They have to speed that up to get the second unit to fire. If it speeds up to 20 hertz before the second unit fires, it's abnormal. If they only stay at 8 hertz with 1 unit firing, you just can't tell. So that's a little bit challenging sometimes. Okay, let's try another one. Determine the firing rate and how many are firing. Pick out one. They're all going to be firing at about the same rate. So we're not going to have one at 20 hertz and one at 5 hertz. So pick out one. What do you think the firing rate is? So 10, some people about 10, 8 or 10. How many motor units are firing? 3 motor units, so normal or abnormal? Normal, so 9 or 10 hertz, 3 units, that ratio is less than 5. You can count them out here. You can see the different units. Here's a big one here. Here's another one. There's a smaller one. There might actually be 4 there. There's 3 or 4. If you use the 10 millisecond sweep, this will sound and look like this. Same clip. So again, the sound is the same. You can learn it by sound. The sound's the same. It's just harder visually to see the rate on this, on the bottom. How about this one? Maximum firing rate and how many? Who thinks it's firing, that one is firing at 10 hertz? Greater than 10 hertz? Okay. How many units are firing? So there's this one. You can see it. And you get a second one, a little burst. The second one, maybe a third one that briefly comes in. So that gets up to about 13 hertz, mainly two units there. So that's mildly reduced recruitment there. And you can hear that motor unit revving up. You can hear it speeding up. Another example. So is this normal or abnormal? Abnormal, okay, reduced recruitment. Firing rate, 15, how many units? 2. Okay, so it gets up actually to 20 hertz, but 2 units. Firing very fast. So that's moderately reduced recruitment. So we'll do 2 more examples here. I gave you the answer, so. That's 10 hertz, 2 units. And how about this one? So this is from a weak patient. That's a little tough, huh? What do you think about this one? So how many units do you think are firing? It's hard, isn't it? So if it's hard, it's probably a lot. They're firing in kind of a burst type of pattern. So there's probably 4 units there. And do you hear any revving up sound that makes you think it's firing very fast, or no? So they're firing about 9 hertz there, 3 or 4 units. This patient's kind of giving away. What do you call this type of recruitment pattern? No what? No, poor activation is the term we use. So this often comes up as, well, how do you distinguish someone that's not giving good effort or has a central process from reduced recruitment? If it's a central process or effort related, you're going to record this. You have a normal ratio. They're firing at a normal rate relative to the number, but this would be a patient who says, I'm giving you the strongest effort I can give you, and you only have a few units firing at a low rate. That's poor activation. It's normal motor units, but they're just not activating. Yeah. The motor unit sound on that example? Yeah, so they're probably a little distant. That's the rise time sound. They sound a little duller. Right, so the needle's probably a little distant to those. And as you know, sometimes in these patients, if they're in pain when you're doing the needle exam, it's hard to keep moving the needle to get close. But you're exactly right. So any questions about, well, let's do 3 more recruitment examples before we go on to other parameters here. So let's again grade this. Someone asked about grading. Is this mild, moderate, or severe? So rate, number, ratio. What do you think? Who thinks this is mildly reduced recruitment? Moderate? Severe? So it gets up to close to 20 hertz there. The shortest interspike interval is up to 20 hertz. 1 unit firing at 20 hertz. So this is pretty severe. If you said moderate, part of it's moderate, part of it's severe, that's okay. But you need to recognize this as reduced recruitment. How about this one? Mild? Moderate? Moderate? Good. So it gets up to about 15 hertz here. 1 unit. Now the second one starts coming in. And this one is mild. 15 hertz, you have 2 units, about 15 hertz. So mild to moderate. So I'm going to pause there for a second. Any questions about recruitment in general? About this process? Right, so the question is, at what rate are you counting? You're counting the rate of each individual motor unit, but you're not actually counting each motor unit rate because they're all going to be firing at about the same time. That's been shown that when you recruit motor units, as the motor units are coming in, they come in at the high, each subsequent unit comes in at a higher rate. They don't all begin at 6 or 8 hertz. So what we're really doing is we're picking out one of them and identifying the rate of that unit, and all the others are going to be very similar. Is that other questions about recruitment?
So what you're saying that if the first is firing at 15 hertz, the second will also start firing at 15 hertz?
About that, yeah. Yeah, they come in at a higher threshold. It's not exact. In fact, it's more complicated than that, but as units are recruited, as they're speeding up and as they're recruited, there's actually a little bit of a drop in the rate. There's some graphs that show a little bit of rate drop that is important in making a smooth contraction. So it is more complicated, but your point is that all the units will be firing at a similar rate. You won't have units firing at 20 hertz and some firing at 6 hertz. Yes? Yeah, so how to distinguish between reduced recruitment and poor activation? Poor activation, the recruitment ratio will be normal. So, meaning the ratio will be 5 or less. As reduced recruitment, you're going to have a higher recruitment ratio. The units will fire too fast relative to the number. The hard part, as I said before, is if you can't get a patient to activate enough to bring in a second unit, or any units at all. That obviously is very difficult. If they can't contract at all, you can't say anything about it. But if they can only fire 1 unit at 8 hertz, and that's it, you can't get them to speed that up, you can't distinguish it. Say that one more time. Upper motor neuron will be poor activation. It'll be poor activation, yeah. Okay, so that's a good point. So the question was, if the ratio is normal in poor activation, how do you know it's poor activation? You have to know what the patient's doing. You have to know that the patient's, you're trying to get the patient to contract at a stronger contraction to speed up those motor units. You don't have to know that for reduced recruitment. I showed you these reduced recruitment examples. If I show you an example of 1 motor unit firing at 20 hertz, you know it's reduced recruitment. That ratio is abnormal. But with poor activation, you guys are exactly right that it'll look normal. If I just give you a clip, it'll have a normal ratio. So you have to know what the patient's doing. That's similar to early recruitment or rapid recruitment. We haven't talked about that, but the recruitment ratio in early or rapid recruitment in myopathies is actually normal. It's a normal ratio. But relative to the force, they're giving just a little bit of force and they bring in a lot of units. At normal rates to number of units, that's early recruitment or rapid recruitment. But that requires a judgment of what the patient's doing. Yes. So the question, did everyone hear that? If you get 3 units firing with a normal ratio, that could be normal, but if they can't activate more motor units, that could be poor activation, yes. Yeah.
The attainment of a full interference pattern require normal recruitment to begin with.
So the question about interference pattern, if you have a full interference pattern, does that imply normal recruitment? I suppose it does. I will say that we don't, in our labs, we don't use interference pattern analysis. For a couple reasons, and there's nothing wrong with using that, but one is it is more painful when patients contracted a strong contraction with a needle in the muscle. Second is if you only do that, you're going to miss some of the other parameters that we're going to go through in a minute, like unstable motor units. You won't be able to identify that if you have a lot of motor units firing. And third, and this is debatable, that you might miss the subtle reduced recruitment where you have 1 unit firing at 11 hertz before the others come in. But if you do interference pattern, full strong contraction, and the baseline's full, and that's probably normal or if anything, very mildly reduced recruitment. Right. There's no lower limit of firing than where you can diagnose myopathy. When you have a patient, even with a severe myopathy, those first units come in at about 6 to 8 hertz. At about 6 to 8 hertz. So that's normal. It's just that it's relative to their contraction. In a normal person, you're going to have 4 units when they start to contract at a moderate contraction. In a myopathy, they just barely move their muscle and they may have 4 units firing at a normal ratio. So you have to know that. You have to judge their effort. Is there a lower limit of discharge of the first motor unit? Yes. It can fire as low as about 4 hertz or so. I don't think they fire less than that. And that's pretty unusual to be that slow. Usually 5 to 6 hertz is the lower. If it's firing at 1 hertz, it's probably not a motor unit. It's probably something else. Okay, so a point about recruitment, and again, I hope you leave after the 2 hours and master this, but you won't, and that's okay, but I want you to leave knowing how to practice this and how to become a master. And this is hard in our day-to-day lives. We're busy, we're rushed, we're doing EMGs and then a patient. But I would encourage you with all these parameters, on each patient you do, 1 muscle, just a couple motor units, try to determine the rate and then visually confirm it. And if you do that, little by little, you'll become very adept and accurate at doing that. Let's move on and just review some examples of other motor unit changes. And these are a little less complicated, I guess, than recruitment. It's either we don't really quantitate these other changes, we just mostly determine are they normal or are they abnormal apart from the duration. So the first morphologic change is stability. When you have a nerve problem, a neurogenic process, and there's early reinnervation, one of the first signs of the motor unit change, in the motor unit change, is unstable motor units. That's because the neuromuscular transmission is immature at some of those newly reinnervated fibers. So when the motor unit's discharging, sometimes some of the neuromuscular junctions work and sometimes they don't. So there's a moment-to-moment change in the amplitude of the motor unit potential as there's addition and subtraction of different muscle fibers in that motor unit. So a stable motor unit means that each time it's firing, it's going to look and sound the same. Just like this. That's very stable. Each sound, don't mistake semi-rhythmic firing from instability. That's semi-rhythmic, but each time it fires, it sounds the same, and this morphology is the same. This example was unstable. And again, you can see that on the right, but you can hear it. You should learn to hear that. I think of that sound of instability as almost like a bongo drum sound. Instead of, it's probably not anything like bongo drums, but instead of bop, 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 it's bop, 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 bop. It has a lot of changing pitch. And this is often overlooked. A lot of times our residents will come out, they'll say, oh, I recorded these motor units, they were long duration, there was reduced recruitment, and we'll say, were they stable or unstable? And, you know, they say, oh, I wasn't paying attention, I was focusing on the size of the motor unit. So this is very easy to overlook if you're not focusing on the stability. Let's test your skill of recognizing stable versus unstable. So who thinks that's stable? Raise your hand. Good. That's a stable motor unit. Who thinks that's stable? Who thinks this is like Simon says? Who thinks it's unstable? It's unstable. Right. It's changing. You can see it changing and hear it. So that's a patient who had early ALS. This is very common in motor neuron disease when there's early reinnervation of denervated fibers. Stable? Unstable? Unstable. This is more subtle. It's a little hard to hear in the acoustics here, but there's a little bit of variability in that motor unit. So that's also a patient with ALS. Stable or unstable? Stable? Unstable? Not as many hands went up on that one, for either. A little tougher. Stable? Stable. That's stable. Good. That's not changing each time it fires. Stable? Unstable? Okay, that patient had myasthenia gravis. Instability, this type of unit will be the only thing you'll see in myasthenia gravis in most patients. Unstable or varying motor unit potentials. So again, we don't quantitate that or semi-quantitate how unstable a unit is. We can do that. That's what single fiber EMG does. But in our day-to-day practice, you need to quantitate the firing rate to determine recruitment, but for motor units you can determine is it just stable or is it unstable. If it's unstable, it tells you there's something wrong with that motor unit, either a neuromuscular junction problem or certainly in neurogenic disorders with reinnervation. The next parameter is phases. A phase is defined as the number of times the motor unit crosses the baseline plus 1. So most motor units, normal motor units, are triphasic. It crosses the baseline here, it comes back down, crosses again here, and then returns to baseline. A polyphasic potential is one that has more than 4 phases, so 5 or more phases. That suggests that the fibers of that motor unit that are firing are not firing synchronously. Usually because there's been some reinnervation. If there's been reinnervation, there's collateral sprouts. Those sprouts may not be fully myelinated, for example. The fibers may be a little bit at a distance. So some of the fibers are firing, the action potentials are a little bit later than the main bulk of the spike. And that gives this ratchety appearance of the motor unit. And if there are more than 15% of motor units that are polyphasic, that suggests there's some problem with that muscle. You're allowed to have some that are polyphasic. So again, we don't quantitate the number of phases. We just determine is it polyphasic or not. So, and they have a very distinctly different sound. Here's triphasic. It's a nice single click. And here's polyphasic. That's very polyphasic. If you counted out the number of times that crosses the baseline, it's probably about 12 phases or so. So it's hard for me to put words to the sound of a polyphasic potential. It sounds hollowish somewhat, but it just sounds ratchety, I guess is the best term I use. So let's see what you think. Triphasic, polyphasic. How many motor units are firing? How many motor units are there? 1. What's the firing rate? We didn't forget about our friend recruitment. What's the firing rate? 8 to 10, I hear. So somewhere 8 to 10. At one point, it's staying at the same spot, so that's about 10 hertz. A little slower at the beginning. So 1 motor unit, 8 hertz to 10 hertz, normal recruitment. It's very polyphasic. Triphasic or polyphasic? Polyphasic, good. So again, you can hear that hollowish sound. You can see the different changes in the morphology. So this first one here, is it triphasic or polyphasic? It's triphasic. But what else do you notice? It's unstable, good. And what else? I think someone said there's turns. So turns and phases are kind of the same thing. A turn is a change in the direction of the spike without actually crossing the baseline. They mean exactly the same thing as phases. And many times if you move the needle a little bit, a turn turns into a phase. So if you have more than 4 turns, changes in directions, that's abnormal as well. It means the same thing, that there's asynchronous firing here. So those have turns. The last parameter, and then we're going to put it all together with a number of examples, real examples, and trying to determine what they have. The last parameter is duration, and that actually is where we spend a lot of our time determining is the size of the motor unit normal or abnormal. Duration is measured as the takeoff of baseline to the return to baseline. And really, the duration is probably the best parameter that tells you the area of the motor unit or the area of the muscle fibers. So motor units, the fibers are spread out in about a 2.5 centimeter, actually it should be centimeter area of the muscle. The duration is 2.5 millimeters. The fibers in 2.5 millimeters of the needle electrode make up the duration. The amplitude is actually made up of just a few muscle fibers that are really close to that needle tip. So even though duration and amplitude sort of change similarly, the duration is a better assessment of the area of the motor unit than the amplitude. So normal duration, what's normal? That's always the question. Normal duration in most muscles, most limb muscles, is somewhere about 8 to 12 milliseconds. That depends on the patient, it depends on the age, it depends on the muscle, but that's kind of a good guideline in most muscles, 8 to 12 milliseconds. If there's reinnervation and there's more muscle fibers now that are part of that motor unit, those muscle fibers are spread out more, so the duration's actually going to be increased. Those tails of the motor unit are made up of some of the perimeter muscle fiber action potentials. So the challenge is determining the duration. And I will say, as much as we're focusing on the sound, our ear, the duration is the parameter that's probably less well-defined accurately based on sound. Our ear doesn't hear these gradual tails very much. It hears the spike duration. But both of those usually change together. So here's a 12 millisecond normal duration. And here's a long duration, 18 milliseconds. You can hear the big boomy sound of it. The amplitude's also increased. Measuring from baseline to baseline, that's 18 milliseconds, so that's long duration. Again, the sound is a little hard. Here, these are almost the same, 12 milliseconds and 14 milliseconds. Listen to the sound of these. It sounds very different. It sounds boomier. But the actual duration isn't much different. The spike duration is, and that's what our ear hears, is this area under that spike. Question? Say that again. We do, on our routine EMGs, the question is what's the low frequency filter set at? It's 20 hertz. 20 hertz. If we're doing formal quantitative EMG, we drop it down to 2 hertz. But in our routine semi-quantitative, we use 20 hertz. Other questions? So this would be a little bit long duration in many muscles. Here's a longer duration, 17 milliseconds. Here's 20 milliseconds. So they become more boomy, more bass, whatever. So what do you think? Let's give you a couple quizzes here. What do you think about this one? Let's assume it's a 40-year-old Altoid. So the question is, does it sound normal, short, or long? Sounds long. Sounds boomy and big. So what would you estimate the duration to be about? 18. And here you do have to use your eyes, so you have to determine this. It is 18 milliseconds. There, so you're right on, visually. Normal or long? Long. What do you think the duration is? So it gets up to 30. This actually has a long tail here that's contributing, so even longer. Okay, with myopathies, the duration obviously shortens. You lose fibers. So here's a normal motor unit. If you have dropout of fibers, there are fewer fibers to summate. The range distribution of those fibers shortens, so the amplitude and duration shorten. And these short durations sound very clicky or ticky. Here's a normal motor unit. "12 milliseconds, and here's one that's 5 milliseconds. It's also low amplitude. What do you think the duration is there? What do you think that is? Is it normal? No? Is it a motor unit? Or is it something else? I'm known to trick the audience sometimes. What's the firing pattern? semi-rhythmic, so it's a motor unit. Duration's only about 2 milliseconds here. This is a 10 millisecond division. It's about 2 milliseconds. That's probably coming from 1 or 2 muscle fibers. That's what a fibrillation comes from, 1 muscle fiber. It's pretty low amplitude. So this goes to someone's question earlier, can you determine based on amplitude what the potential is? Absolutely not. This is a very short, pretty low amplitude motor unit potential. What's the duration of this one? Short? How short? About 5 milliseconds, so 5 or 6 milliseconds. So this is going to be mildly short in limb muscles, depending on, again, the age and the patient. If it's an 80-year-old in the anterior tibialis, this is very short. If it's a 30-year-old in the biceps, this may be just mildly short. If it's a cranial muscle, this is probably normal, facial muscles. So it really, you have to learn from each muscle. Duration? Normal or abnormal? Normal. So that's about 10 milliseconds there, normal motor unit. Questions about any of those other parameters? Yes? Right, so the question is, do we include amplitude? We do and we don't. We do grade it. We have a column on our report that says amplitude. The problem is we don't rely a whole lot on it because you can have, like that myopathy example, that very 2 millisecond potential. Yes, it was a little short, but it may not be of abnormally low amplitude. So if your needle is very close to 1 muscle fiber, that can maintain the amplitude of the potential. So it's not the best parameter to determine the size of the motor unit. Now, saying that, most of the time, if we have 1 plus long duration motor units, we probably have 1 plus high amplitude. Those go hand in hand, but not always. I would probably not. If you have an amplitude that goes off, but the duration is 10 milliseconds, I would probably mark it as high amplitude, but not interpret it as abnormal. And the other issue, as we're talking about auditory recognition, is our ear doesn't hear changes in amplitudes very well. That just changes as loudness of the spike. It doesn't change in boominess or other sounds. So it's very hard to be accurate in your amplitude assessment just by sound alone. Can you speak up just a little louder, please? Yeah, that's a good question. So sometimes if you have a distant motor unit that seems long duration, I think is what you asked. How do you differentiate that? So, I think that's what you asked? So you want to assess motor units that are close based on rise time. If they're distant, I ignore them, or I move the needle till I get close to those units. In fact, most distant motor units will be shorter, will appear shorter in duration and much lower in amplitude rather than longer. But you have to be close to the unit, and that rise time sound, you're probably familiar with it. It becomes sort of clickier when you're within 500 milliseconds instead of a motor unit that sounds, I don't know if I can mimic it, but that sounds like boop, 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 boop. It's tick, 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 tick. That sharpness tells you you're close to the unit. And that's when you want to make all your assessment.
Do you consider the doublets and triplets units or a sort of podcast?
Right, so do you consider doublets and triplets, they're two different units or part of the same. They're the same unit firing twice, so you don't include the duration of both of them in your duration measurement. You only include one of them. Same with a satellite spike. A satellite spike is you have your main spike and you have a time lock component, which is probably a long nerve twig innervating one fiber. That's not included in the duration measurement either. It's just the main spike that we're measuring.
What's an acceptable lifetime?
What's the...
Acceptable lifetime. What is considered normal?
So the question is, what's an acceptable rise time? We like the rise time to be 500 milliseconds or less. There's not a set cutoff because the rise time actually is dependent on the amplitude of the spike too. So what your ear's hearing is the slope. It's the rate of rise. If you have a sharp slope, but you have a high amplitude potential, the actual rise time is going to increase. So it's not an absolute number that we look at. Yes.
What about duration in the polyphasic?
So duration and polyphasic potential. So we measure duration in a polyphasic potential from takeoff of baseline to return to baseline, just like we would for a triphasic potential, because that's part of the motor unit. That polyphasia, that's all one motor unit. So we measure that duration. Now, some people, when they make their assessment, they'll assess a mean duration of all potentials and then separate out the ones that are not polyphasic, because that can increase the duration. If you have some that are triphasic and have shorter duration than the polyphasic increase, some people do that. And in quantitative EMG, they'll separate those out. We don't. We just include them all as figure out the mean duration of all the potentials.
In weak myopathic muscle, do you ever isolate the minimal contraction?
So in a weak myopathic muscle, can you isolate one motor unit with minimal contraction? Maybe. I mean, it depends on how bad it is. If it's really rapid recruitment, probably not. If it's a mild myopathy, sometimes you can, but it is difficult to do that. Difficult in normal people many times to do that too.
Can you comment on concentric versus monopolar?
So question or comment on concentric versus monopolar needles. What do you want me to comment on? Does it change the assessment? So we use concentric needles in our lab. That's what we've always used. The difference is the pickup area is a little bit different between the two. The concentric needle has a smaller pickup area. So the motor units will be a little bit shorter, a little bit lower in amplitude than monopolar needles. It's a mild difference. There is some data, older studies looking at that. Some suggest that motor units are about 1.3 times bigger with monopolar than concentric, but I haven't looked at that. And I think it's what you're used to. You know, if you use a certain needle type, you're used to it. You know what's normal for that needle.
Which one is the clue to differentiate chronic lymphitis from the distal? The pattern of the EMG waves?
So how do you distinguish a chronic myositis from a dystrophy? Well, you often can't. So in myopathies, whether it's a dystrophy or an inflammatory myopathy, you'll classically get short duration motor units, polyphasic motor units, and rapid or early recruitment. I think what you might be getting at, and the challenging cases that we see, is when a myopathy is chronic, that you can have remodeling and reinnervation of the motor units. So some motor units actually are normal size or even maybe longer duration. That's classic in inclusion body myositis, where they may look neurogenic. And that's hard. The evolving neurogenic motor units and long-standing myopathic motor units can overlap. So the things I use is I look to see, are there truly really big units? Is there reduced recruitment? Are in myopathies, you'll often have some background motor units that are much smaller, hidden behind the bigger units. So I'm paying attention to all of that. But those are hard cases. Yes?
In
I missed part of that. Say that one more time, please. In,
Small muscles like quadricularis oculi and the large muscle like quadriceps, the same MEMP configuration. MEMP configuration is the same.
no, they're not the same. The motor unit configuration is different in muscles. So, I mean, that's been shown in the number of muscle fibers in a motor unit are different in the facial or the extraocular muscles. There may only be 5 muscle fibers in a motor unit. In the gastroc, there are 2,000 muscle fibers in a motor unit. They're spread out, but the configurations are very different in muscles, and that's why you kind of have to know what's the normal size of motor units for each muscle. You know, again, most limb muscles will be somewhere in the 8 to 12 range, but you have to know those exceptions. So with the last, we still have a little bit of time, 10 minutes or so. We'll go through a couple quizzes. We'll put them all together, all these parameters together, and try to determine what the disease is. So here's the first example. So what's the firing rate? 8 hertz. What's the duration? (13 milliseconds). Is it triphasic or polyphasic? Triphasic. Is it stable or unstable? Stable. Good. So what kind of condition would this example be seen in? Normal. It's a normal motor unit. How about this one? Firing rate. (8 hertz). Duration. Short. How short? 3 milliseconds. Is it triphasic or polyphasic? It's hard to see, but you can hear. Triphasic. Is it stable or unstable? Stable. So what condition would this be seen in? A myopathy, some type of myopathy, probably. Why not a neuromuscular junction disorder? It's stable, right. Why isn't it a fib? Semi-rhythmic, good. Very tiny single, which would look identical to a fib. If this was regular, it would be a fib. Could it be a cranial nerve muscle? This would probably be a little short for cranial muscles still. There was a paper that came out maybe 2 years ago looking at normal values in some of the facial muscles. I think their lower limit was about 4 or 5 milliseconds. But it would be close, you're right. Third one. Firing rate. 20 hertz. At fastest is 20. Duration. (18 milliseconds), so it's long. Triphasic or polyphasic? Triphasic. And is it stable or unstable? Stable. Good. I'll play it again. Okay, where might we encounter this? Okay, I think I heard it in many different ways. So this would be a neurogenic process where there's been reinnervation, there's been loss of motor units because there's reduced recruitment, there's been reinnervation, they're long duration, and it's been long standing. right? They're not polyphasic, they're not unstable, so the reinnervation has matured. So it's been chronic, whatever that means, over 6 months or so. Okay, any type of neurogenic process. How about this example? Rate. Rate. 12 hertz, a little bit faster. Duration. Nine milliseconds. Phases. There's some little turns there. It's triphasic, but there's these little turns. And stable or unstable? Unstable. So it's really quite variable. You can see that and you can hear it. So where do you think this was recorded from? So could be myasthenia gravis. Yeah. Yeah. What's unusual for myasthenia? What might be unusual? Duration's okay. This is a normal duration. Well, it's unstable. That's classic for myasthenia gravis. The rate's a little bit fast. That would suggest reduced recruitment unless this was a cranial muscle, which it actually was. Those fire a little bit faster. And in severe myasthenia gravis, if you have a lot of blocking of lots of fibers, you can occasionally have some reduced recruitment. That's exceedingly rare, but in cranial muscles, they'll fire that fast. So this actually was, or where else, let me ask you this, where else could this be seen if it wasn't myasthenia? Yeah, so this could be in an early reinnervation. You could have an acute neurogenic process within the first few weeks or month. As there's early reinnervation, you'll have some reduced recruitment. The duration hasn't really increased much, but you have a lot of instability. So it could be either of those situations. Okay, rate? 18. Duration? Is it normal, short, or long? It's actually about normal. From here to here is about 8 milliseconds. Polyphasic. And is it stable or unstable? Unstable. So there's some spikes that are sort of dropping out here. So what's this? A what? It's low amplitude too, right? So, okay, so it could be a myopathy, maybe. So who thinks this is a myopathy? Some of you, that's okay. Who thinks it's something else? Okay, could be something else too. What's unusual for myopathy here? The high rate, so it's very reduced recruitment. And again, in severe myopathies, end-stage myopathies, where you lose entire motor units, all the muscle fibers in entire motor units, you can have reduced recruitment. So it doesn't exclude that. But what else is unusual for myopathy? The duration, okay, you might think it should be shorter, but as we answered a question earlier, sometimes with chronic myopathies, as there is some reinnervation, the duration is maintained as normal. Instability. It's very unusual for myopathies to be that unstable, the motor units. It's really, there's a lot of blocking and change here. So you have reduced recruitment, you have unstable motor units that are low amplitude. So early reinnervation and there's a term that's sometimes used for these type of units. Nascent. Yeah, this is a nascent motor unit, a brand new, early reinnervating motor unit where the new collateral sprouts or the new unit is only innervating a few muscle fibers. That's typically seen in trauma, nerve trauma, plexopathy trauma, as there's early reinnervation. And the difference, again, between myopathy here, although always there can be some overlap, but the markedly reduced recruitment and the instability would be unusual for myopathy. These are the killers in a lot of patients. Yeah, these are harder ones. In nascent units? You mean in nascent units or in myopathies? Yeah, so myopathies, again, the point that's been made, and I think it's important to reiterate, is myopathies, the motor units can be quite variable. So I showed you a couple of examples of myopathies. I've shown you one where it wasn't polyphasic. It was 2 millisecond, one spike. That was a myopathy. And maybe that's a myopathy where it's a congenital myopathy or something that there's not a lot of necrosis and reinnervation of the fibers. You can have myopathies like this, if this was stable, that are mildly short and mildly polyphasic, or you can have myopathies that are longer duration and very polyphasic, depending on the chronicity and the reinnervation. So you're exactly right, and myopathies are much harder than obvious neurogenic type of problems. So let's do a couple more examples. We have two more minutes here. We'll do 2 more examples. So this was a 34-year-old that had arm and shoulder pain. This was from the biceps. So what do you think, what type of condition is this? I gave you multiple choice here. It'd be nice if our patients came in with a multiple choice list of diseases. I have one of these 3. What do you think? Normal. What is this? End plate spikes. Irregular end plate spikes and a normal motor unit potential. So let's go through a couple other examples. Same scenario. So I'm hearing subacute. People are thinking 3. Anyone think it's 5? Some people are thinking 5, myopathy. Anyone think it's something else? 4, chronic? Anyone for anything else?
Well, I think it's a nascent unit, but again, it could be a myopathy with
Okay, so here, what is this? Everyone agree it's regular? It's a fibrillation? Okay, that's a fibrillation, which doesn't help with most of these, right? Most of these can have fibs. So let's go back. Let's summarize everything we've done in the last 2 hours. Listen to this unit. What's the firing rate? How many units are firing? Triphasic, polyphasic, stable or unstable in duration? So maximum firing rate, it gets up pretty quick, yeah. Start slow. Now it starts speeding up, and it has an inner spike interval of about 100 milliseconds there, or 20. It's about 20 hertz there. Okay, so 20 hertz, reduced recruitment, Stable or unstable? Unstable. Polyphasic or triphasic? Polyphasic. And what about the duration? So duration here is maybe 10 milliseconds or so. So pretty normal duration. So this is, the answer here is 3. Okay, this is another, it's not truly a nascent unit. Nascent units are going to be a little shorter, but it's an early reinnervating motor unit. The difference that I just described from a myopathy is the reduced recruitment and how unstable that is. That's unusual for a myopathy. Question? Where do you mark it? It's a little hard where I stop it because you have some background distant motor units. So right here, let's see, I would probably mark it from here to here. So here it's about 6, maybe about 6 or 7 milliseconds there. So maybe a little short. It's hard when you have more than one or an unstable baseline to know exactly where to mark it. All right, that's been a full 2 hours. Please remember everything we learned. I hope you've mastered EMG, and if not, you know what to do to master it. And thank you.